Hi, everyone. Welcome. My name is Erica Mills. I am a family planning and reproductive health technical advisor on the Momentum Integrated Health Resilience Project, and I will be moderating the session today. Today we have a very interesting session on family planning programs in emergencies. We will hear from 4 different speakers who will give from the conceptual level down to implementation, a bit of information about their family planning programs in emergency settings. And then afterwards, we'll have a little bit of time for Q&A. So looking forward to it, and I am glad that you're all here. So our first presenter for the day will be Christopher Lindahl. Christopher is the Knowledge Management Lead for Momentum Integrated Health Resilience. In this role, he also leads and coordinates adaptive learning and adaptive management for the project and supports strategic communication efforts. He has over 10 years of experience supporting and leading knowledge management efforts for global health projects and organizations in both humanitarian and development settings. Before joining Pathfinder International and Momentum in 2020, he spent time with Save the Children and Engender Health, and he holds a Master of Public Administration from New York University. Christopher, I will pass it over to you.
Thanks, Erica, and thanks everybody for being here. Thanks to the fellow panelists. I'm here to present some work that was done by Momentum with some of our colleagues at the Johns Hopkins Center for Humanitarian Health, including Paul Spiegel, Amani Kadur, Haley Hoagland, and then some Momentum colleagues, Melinda Pavin and Katie Morris. Just before I jump into that work, a little bit about Momentum. There are 6 Momentum Awards. I hope you've heard about some of them by this point today, that work alongside governments, local and international, private and civil society organizations and other stakeholders to accelerate improvements in maternal, newborn, and child health services. Momentum Integrated Health Resilience specifically works to strengthen health resilience and continue providing high-quality services in fragile settings. The work that I'm presenting today is based on a landscape review that was done to develop a conceptual framework for public health in the humanitarian development nexus and create specific recommendations for how development actors can operate and work in those settings. This is all based on a desk review of published in gray literature and key informant interviews with development and humanitarian organizations, both based kind of at the headquarters level, but also at the field and implementation level. The interaction between humanitarian and development actors is not a new concept. You may have heard of the humanitarian development divide, the gap, the continuum, and these go back decades, these conversations, but they really provide an incomplete description of the reality of this work on the ground. So the nexus kind of marks a turning point in the thinking about this. It's not just a new kind of word or rephrasing of it, but it was really the recognition that there's not a transition from humanitarian work to development work. In settings, you see transitions back and forth. You see development actors and humanitarian actors working in the same space, and you see improvements and then new shocks and stresses come in. So the terms transition in particular is problematic for that reason, because in places where we work and others like South Sudan, Eastern Congo, you have both development and humanitarian actors working. Before I jump into the framework, which is what I want to spend most of the time presenting, just a few key findings from the desk review of the literature, as well as the key informant interviews. So across humanitarian and development actors, there's broad consensus about the importance of family planning, the need to ensure access to high quality family planning services, and a rights-based approach as well. However, with differing mandates, differing ways of financing and planning, and information sharing platforms, all of these lead to challenges in terms of collaboration and working between humanitarian and development actors. There is, however, robust evidence from a number of implementing partners. You've maybe heard from some of them today on the humanitarian track or this week from places like Save the Children, IRC, CARE, Columbia University's RAISE initiative, all showing the feasibility of providing high quality family planning services in fragile settings, and also that there is strong demand for those services. But currently there's actually little documentation of how development programs operate in fragile settings. Most of that documentation and work is coming from the humanitarian side. So thinking about a place like Eastern Congo, there's good evidence from the humanitarian family planning programs, but less evidence from the development perspective. And just in general, when it comes to the humanitarian development nexus, most of that thinking has been done by the humanitarian world and humanitarian actors. And so that's why we came into this thinking about the humanitarian development nexus from a health and development perspective, because the project Momentum Integrated Health Resilience is very much a development program. We're not a humanitarian program, but we're operating in settings where you have a lot of humanitarian actors. And in many of those places, the humanitarian actors are the more prominent actors, again, Eastern Congo, South Sudan, Northern Mali, and places like that. So we started just looking at some of the literature and thinking about some of the key considerations and things like that for humanitarian or for development actors. So really focusing on complementing and enhancing work that's already being done around resilience, thinking about different ways to engage a wide range of actors, both humanitarian and development. So for example, this could be something like development actors playing a greater role in the health clusters coordination systems. And also to ensure that development actors are embedding things like preparedness into their programs. It's becoming more common recently for development actors to be focusing on preparedness, but for a long time, a lot of the preparedness work was being done by humanitarian actors who didn't have the same reach that development actors may have. So looking at again, through the literature review and interviews, we came up with a conceptual framework for maternal, newborn, child health, family planning, and reproductive health in the humanitarian nexus, or humanitarian development nexus. For the most part, this is pretty integrated, so across that spectrum, not just necessarily a focus on family planning, and is based on existing frameworks for the humanitarian development nexus from the United Nations, as well as some health system strengthening work from WHO and USAID. You can see the core components at the top, collective outcomes at the bottom, and then kind of the contextualization in the center. And so those are the three pieces of this that I'll focus on before getting to some recommendations. In terms of outcomes, I think these are all pretty straightforward and things that we can all kind of relate to across humanitarian and development approaches. The one that I will just focus on briefly is around the resilience one, to just talk a little bit about that and how we at Momentum define that as the ability of people, households, communities, and health systems to prepare for, mitigate, adapt to, and recover from acute, recurring, and ongoing shocks and stresses in a manner that reduces disruptions to access and use of quality health care. The next thing that I'll talk about are these core components across the top. And again, these may look familiar if you're familiar with various health system strengthening frameworks. So we have leadership, governance, coordination, financing, analysis and planning, and information management. And so the landscape analysis, which I'll show a link to at the end here, goes into kind of identifies the current status of these when thinking about development and humanitarian actors, and then provides some ideas or recommendations on how to kind of approach that from a nexus framework and thinking about improved coordination in particular. As many of you may know, particularly on leadership and governance, as well as financing, there are a lot of parallel systems in place where you have humanitarian on one side and development on the other. And so again, I mentioned the cluster system. That's kind of one of the areas in terms of coordination where we can see a lot of opportunities for improved collaboration and embedding development actors in there as well. And then on the financing side, again, with the separate with donors, separate parallel systems, essentially. And so there are opportunities there for streamlining that, whether it's through crisis modifiers or flexible funding opportunities, as well as the potential for more innovative approaches, particularly around preparedness, thinking of things like bonds and insurance and that type of thing. And then finally, the last one I'll touch on is information management. As a knowledge management person, that's something that's near and dear to my heart. But on the humanitarian side, for example, you have kind of clearinghouses that like Relief Web or humanitarianresponse.info, but nothing comparable exists on the development side. I was in Colombia for the Health Systems Research Symposium a couple of weeks ago, and was sitting in on a session where someone was talking about a COVID hub of hubs, because they were able to identify 300 different places around the world claiming to be a hub for COVID information, so that they had to create this hub of hubs. And so again, that just being one example. The last thing to focus on in the framework before I get to the recommendations is to just look at this contextualization piece of it, as well as some of the principles in terms and norms. It's quite small, but and so you may not be able to see it, but we have quality, norms, principles, and localization, which are all, I'm sure, terms and things that you're familiar with. The one that I'll just focus on briefly are the principles, just because, again, within the humanitarian community, you do have the humanitarian principles of humanity, neutrality, impartiality, and independence, which I think sometimes can become problematic issues in terms of working with governments who may be, party to conflict or something else in the area. So I'll close with some recommendations that came out. Again, at the end, you'll see a link where you can go and get a lot more detail about this. But the first is, again, ensuring some complementarity between humanitarian and development programs in terms of financing and donor mandates. I've talked about donors a couple of times, as well as financing. But identifying ways to integrate that funding or have it work together in a more meaningful way. Certainly joint preparedness and planning, again, where does preparedness fit within humanitarian and development actors, and making sure that there is complementarity there, so that it's not being done solely by the humanitarian community. Of course, you have short, medium, and long-term considerations for health interventions, and keeping all of those in mind, so that when we're responding to a humanitarian emergency, we're not, implementing the MISP, where you're doing the immediate short-term life-saving interventions, but as soon as possible, transitioning back to comprehensive services. Thinking about this from a health system strengthening approach throughout the course of an emergency, to the extent that that's possible. Certainly greater sensitization and socialization of development actors. And this is where, again, I think we're starting to see more development actors playing a role in the cluster system, which I think is a great opportunity for additional collaboration. And then just continued documentation of all of these efforts. As I mentioned at the beginning, the review found a lot of documentation around family planning efforts from the humanitarian community in these types of settings, but far fewer examples on the development side. And so I'll just wrap it up there. And just in terms of some of the next steps that we're doing, this work that I'm presenting now is just the first step of some things that we're doing. We're in the process of developing case studies in 4 countries: Mali, South Sudan, and Yemen. And these will look at nexus programming more on the ground, and to see how development actors and humanitarian actors either are or aren't working together and collaborating in settings where both are operating. And you can find more. All of this is available on the Momentum website. There's a short link there. I probably should have done a QR code, but if you go onto the Momentum website, you certainly can find all of this information. Thank you.
Great, thank you, Chris. I think this HDN framework is super interesting, and it will be really helpful, both the framework and the work that's following it, as we as a community think about how humanitarian and development actors can collaborate more closely for sustained impact. So with that, we will go to our second presenter, Brian McKenna. Brian is the Deputy Director of the Reproductive Health Supplies Coalition. In his role, he is responsible for co-managing the coalition's global activities, including oversight of technical staff responsible for implementing global and regional initiatives focused on supply chain management, market dynamics, and advocacy. Prior to joining the coalition in 2014, he worked for 11 years for Population Services International in Zambia, Madagascar, and Washington, D.C. Brian holds a master's degree in international affairs and economics from the Johns Hopkins University School of Advanced International Studies. And with that, Brian, I pass it over to you.
Thanks. All right. So, yes, I'm the Deputy Director of the Reproductive Health Supplies Coalition, which is a multi-sectoral network of organizations all working to increase access to quality, affordable reproductive health supplies in low and middle income countries. It's my pleasure to be here today in person to present our collective work to strengthen supply chains for sexual and reproductive health through collaboration in the humanitarian development nexus. Partners collaborated on this, and many of them or some of them are here today, and I'm honored to represent them. In addition to RHSC, they include the Interagency Working Group on Reproductive Health in Crisis, FP 2030, UNFPA, the Women's Refugee Commission, JSI, Emory University, Palladium, and CARE. So yeah, this will just give you a quick idea of what I'm going to present in this presentation. So following the introduction and context setting, I'll talk a little bit about the importance of preparing for and transitioning from crises, as well as a call to action for focused on particular target groups. Hello. Oh, there we go. Okay. So, to achieve universal access to sexual and reproductive health by 2030, as stipulated by Sustainable Development Goals, governments, UN agencies and donors, and national and international NGOs must work together to improve access to SRH supplies across humanitarian and development settings. As you might imagine or know from this experience, this is not as easy as it sounds, but the benefits are well worth the effort. To bridge the humanitarian and development sectors and improve or promote coordination, we brought together stakeholders from the RHSC, IWAG, including partners from both sides of the humanitarian and development nexus. This represented the first time the humanitarian and development SRH communities have come together to identify shared objectives and concrete joint activities. Between 2018 and 2021, we convened 2 in-person meetings, held multiple interactive webinars, and established a joint community of practice, which culminated in 2 co-published briefs compiling expert recommendations on strengthening supply chains across the humanitarian development nexus. Released in 2019, the information brief, which can be accessed using this QR code, compiled supply chain strengthening activities that humanitarian and development sectors can collaboratively undertake during pre-crisis preparedness and post-crisis recovery to build more resilient SRH supply chains. Building on this brief, a range of humanitarian and development stakeholders from the RHSC and the IWAG jointly developed a set of recommendations specific to 4 target audiences on how supply chain resilience across the spectrum of settings can be improved through their actions. The recommendations were drafted in an in-person meeting in 2019 and then reviewed and vetted by stakeholders in 2020. The RHSC and IWAG stakeholders leveraged the start of COVID-19 pandemic to underscore that humanitarian and development supply chain actors can be more effective in their respective efforts by working together. The recommendations articulated will benefit people affected by and at risk of being affected by crises globally, and will contribute to improving access to universal health care in line with Sustainable Development Goals by focusing on the points where humanitarian and development work converge. Reflecting the information brief, this presentation will outline the importance of collaboration, identify entry points, and share a call for action to invest in 2 critical transition points along the humanitarian development continuum: pre-crisis preparedness and transitioning after acute emergencies to more sustainable supply chains. The pre-emergency and post-acute stages present opportunities for humanitarian and development partners to work together in key areas. The recommendations in the brief and this presentation are based on expert consultative processes and pilot projects. However, investments are needed to further test these and document these promising practices. So as we all know, every country is vulnerable to crises, natural or man-made, with record numbers of people displaced annually. Humanitarian contexts are becoming more protracted, and the impacts of crises and displacement are lasting. In fact, humanitarian crises disrupt development gains, derailing hard-won progress, access to life-saving commodities and services. This image from the Informed Global Risk Index website clearly shows the challenging global landscape, which increases the need for systematic collaboration. On this map, the darker the color, the more at risk the country. So the current global trends underline the increasing needs. Natural disasters have doubled over the past 2 decades. More than 1.5 billion live in countries at risk. 89 million people were displaced globally as of 2021. 17 years is the average length of conflict-induced displacement. Nearly 60% of people displaced are living in their own country, and more than half of refugees live in cities. So everyone has a right to SRH services, including in crisis settings. Women continue to menstruate, become pregnant and give birth when a crisis strikes. The point was underlined at the World Health Summit in Berlin in October, where UNFPA Director Natalia Kanem said, "Periods continue in a crisis. That's biology." Women and girls affected by crises face an increased risk of mortality and morbidity, unintended pregnancy, and sexual violence. At the same time, health systems are disrupted and access to life-saving SRH supplies is compromised. Sexual and reproductive health care is an established life-saving component of an emergency response. Oh, now I got 2. Here we go. Okay. So when emergency strikes, affected populations need uninterrupted access to basic life-saving health care, including SRH services. The minimum initial service package for sexual and reproductive health services in emergencies outlines life-saving SRH services, including safe and clean delivery, emergency obstetric and newborn care, access to a range of short-acting and long-acting reversible contraceptive methods, sexually transmitted infection, syndromic management, and HIV prevention and care that must be available from the earliest days of a crisis response to save lives. The MISP is part of the Interagency Field Manual on Sexual and Reproductive Health in Humanitarian Settings, which also details comprehensive SRH services that actors should provide after an acute emergency response, including guidance on managing commodities. Yet access to life-saving SRH commodities is often lacking. The Interagency Reproductive Health Kits, shown here, for humanitarian crisis situations managed globally by UNFPA, provide the medicines, devices, and commodities necessary to implement the service objectives in the MISP and save lives. The IRH kits are designed for settings with weak capacity to provide minimum life-saving aspects of care at the outset of a crisis. The IRH kits are neither context-specific nor comprehensive, as they are designed at the global level to initiate immediate life-saving services in an acute emergency response. So the term humanitarian calls to mind the chaos of at the onset of a natural disaster or conflict. However, acute humanitarian response is often relatively brief, requiring a specialized response centered on the most life-saving interventions. Therefore, many entry points to improve continuity of national supply chains occur before or after the onset of an acute crisis, rather than at the height of the emergency, when information availability and humanitarian access are limited. The emergency programming cycle captures these stages and is useful for considering entry points for improving national supply chains. The cycle shown here illustrates the interconnectedness of each phase, from preparedness for an emergency, the humanitarian response, and the transition into protracted response and recovery. In the next few slides, I'll talk about the preparedness and transition in more detail. So the first critical point in preparing to meet SRH supply needs in crisis. Preparedness measures can facilitate meeting people's SRH needs in the event of an emergency by anticipating risks and mitigating the impact of potential lack of essential health supplies. Humanitarian actors understand the challenges faced in emergency response, while development actors are more likely to be present before an emergency strikes. Governments and stakeholders across the spectrum of humanitarian and development settings can undertake a variety of measures to improve global and national preparedness. First, create an enabling environment to facilitate rapid entry of SRH products into country in the event of an emergency. Map out likely needs, challenges, and contingencies along the supply chain. Strengthen national human resource capacity to manage SRH supplies in the event of an emergency. Integrate emergency SRH services, supplies into logistics management and information systems. Improve coordination mechanisms across partners to improve supply chain functioning in emergencies. And decentralize stock regionally or pre-position key supplies when strategic. So I have an example here. In the preparation and the response to the earthquake in Nepal in 2015, this serves as a good example. Reproductive health and primary health care supplies were available at the outset of the crisis only because they were pre-positioned. During the destruction of essential infrastructure needed for import, supplies not pre-positioned only reached the last mile after substantial delays. Whoa. So the second critical point that is that of transitioning to a more informed and sustainable or stable supply chain after the emergency response. During acute crises, the collapse of the health systems is common, including interrupted health supply chains, the disruption of health facility infrastructure, death or displacement of healthcare personnel, and a lack of access to functioning healthcare facilities. Once the initial chaos of an acute emergency subsides, even in protracted emergencies, work can begin to reestablish or repair national supply chains. Effort should be made to support this transition from a kit push system to a pull system or an informed push system, enabling procurement to be more responsive to local demand and consumption and more cost effective, reducing both waste and stockouts. Supporting the transition away from exclusive IRH kits procurements will also enable an expansion of SRH services beyond the MISP to a more context-specific and comprehensive SRH response customized to local evolving demand patterns, disease burden, and national health systems. Several measures can be undertaken to transition from an emergency supply chain to a sustainable, stable supply chain through collaboration across partners, including UNFPA as the main supplier of SRH commodities in acute emergencies, governments, and other stakeholders. So on the list is to prepare to decrease reliance on IRH kits, strengthening humanitarian capacity across partners, governments, UN agencies, and NGOs to transition from the acute emergency supply chains to more stable supply chains. Strengthen logistics and supply chain data collection and use it to inform supply planning and quantification. Strengthen the infrastructure for national supply chains. And another example here for this is from Cox's Bazar in Bangladesh, where UNFPA and JSI collaborated to guide the UNFPA Cox's Bazar team responding to the Rohingya refugee crisis on how to transition from IRH kits to individual products. The team collected data to map the current supply chain, including flows of funding, information, and products, made recommendations for supply chain strengthening activities, built capacity in forecasting and supply planning, and provided a forecast and a supply plan for individual products. Some examples of the outcome of this work included recommendations for UNFPA and the local authorities to determine inventory control protocols and order frequency, collect several months of particular data, implement an LMIS system, assess the need for increasing warehouse space, and conduct the capacity building for key partner staff, and inform partners of changes and new expectations in advance of transitioning. So all stakeholders, governments, partners, and donors working across the spectrum of humanitarian development settings, including UN agencies, national and international NGOs, can contribute to improving SRH supply chains by collaborating to strengthen pre-crisis preparedness and transition after acute emergencies to more sustainable, stable, and uninterrupted supply chains. The advocacy brief, which may be accessed using this QR code, focuses on a call to action for each particular group. So governments can contribute by taking the leadership and creating an enabling and policy environment to facilitate meeting SRH supply needs before, during, and after a crisis. Including SRH supplies and a disaster preparedness and disaster risk reduction plans, and including crisis planning and preparedness in the health sector development plans and data collection systems. Integrating crisis-affected regions in national supply chain management, planning, and design, and supporting a pre-registration of supplies, including the IRH kits and including a bulk items imported in humanitarian import exemptions. So humanitarian and development actors can contribute by developing common global training packages, tools, and guidance to support national supply chain preparedness and transition to sustainable supply chains, and establishing standards for measuring supply chain maturity and key performance indicators in humanitarian settings, improving global and national coordination, data sharing, technical expertise, building on the newly established humanitarian health supplies subgroup of the Interagency Pharmaceutical Coordination Group and other coordination mechanisms, building logistics capacity at the global and national levels, including a surge deployment roster of medical logistics experts, working with WHO to support pre-qualification of manufacturers providing key bottleneck for SRH items, and working with UNFPA on transitioning from the exclusive procurement of IRH kits to bulk items, and coordinating with local health supplies partners to find solutions to key issues that affect preparedness initiatives and bulk item procurement. So I'll just continue here that donors can contribute by providing leadership and advocacy on the need for collaboration across boundaries, investing in projects that will work to improve supply chains across the nexus, investing in research that generates evidence on what works to improve supply chains in the humanitarian development nexus, investing in medical supply chain experts and pharmacists, developing and employing the training packages and tools and guidance, and ensuring that humanitarian funding structures are flexible, and establishing projects with long-term funding cycles. So while humanitarian actors have a clear mandate in new crises and development actors have a remit in stable settings, fragmented humanitarian and development funding and implementation mechanisms do not adequately meet SRH supply needs and lead to both shortages and waste in supply chain systems. All settings are at risk of crisis and can last a decade, and the entire world can be disrupted, as we know, by a global pandemic. So in line with commitments to improve multi-sectoral collaboration, governments, donors, and partners working across the spectrum of humanitarian and development settings, including UN agencies and national and international NGOs, they all should all work together to seize significant existing opportunities before crises strike to improve preparedness and after the onset of an acute crisis to expedite the transition to more sustainable, stable supply chains. In order to do this, governments, donors, humanitarian agencies, and development agencies, as well as the private sector and partners, must collaboratively work together to develop and implement strategic solutions that have lasting impact. The recommendations advanced in the joint IWAG RHSC briefs enable the collective SRH community to advance access to universal health care by preparing better and building back better. We must work together to adopt our actions before, during, and after crises to build more resilient supply chains, reduce the chronic vulnerability that SRH supply chains, and ensure that women and girls globally can continuously access the life-saving SRH supplies they need. So again, many thanks to the partners who worked together on this, including in particular my co-authors on this abstract, Sarah Rich from the Women's Refugee Commission and Sarah Stratton from Palladium. Thank you.
Thank you, Brian. I really enjoyed how your presentation looked at the supply chain holistically from information systems, health workforce, infrastructure, et cetera, especially in those kind of two key points you mentioned, both the pre-crisis preparedness and then the post-acute crisis transition to recovery. I also kind of noticed between you and Chris's the importance of coordination and in collaboration among actors, so I think that's coming out super strongly. Now we have our third presenter, who is Jana Lowski. Jana is the Manager for Sexual and Reproductive Health and Family Planning and Emergencies at the German Red Cross. She is advising and supporting the development of a standardized family planning approach within German Red Cross and other interested national societies around the globe. Jana has been working with several organizations and universities before, always with a focus on maternal and reproductive health. She is a registered midwife and holds a Master in Education from Free University Berlin. Over to you, Jana.
Thank you, Erica. Well, it's a pleasure to be here today. I'm Jana. I'm presenting to you our project, The Power of Collaboration, but how we're going to integrate family planning services into emergency response units from German Red Cross. And we just learned from you that active humanitarian action or active response is needed, and this is what we're doing. Okay. Okay, that would be great. Thank you, Erica. So before we start, I just want to give you a brief disclaimer. The featured project I'm talking to you about is a project based on an agreement between Bayer and German Red Cross. It's funded by Bayer, but the final product, the family planning module, will be owned by German Red Cross. Both partners agreed to co-develop the featured project, to share a shared utilization of logos, and to follow each other compliance guidelines. For German Red Cross, that means specifically that we are free to choose a supplier of our own choice, meeting our procurement regulations, and we are not obliged to use any Bayer products. This is very important for us because of the 7 principles of the Red Cross movement: independence and neutrality. Next, please. So I'm going to take you on a little journey today through the Red Cross, Red Crescent movement, what family planning is about in emergencies at German Red Cross and other national societies, what we have learned so far, how the partnership approach actually worked for us, and the considerations for the future. Next, please. So German Red Cross is part of the largest humanitarian movement in the world. And I just learned that there are volunteers from the Thai Red Cross here, so and there might be more, I don't know, and that's a really great meeting you. So we are part of the largest humanitarian movement with 192 national societies in almost every country in the world and more than 14 million volunteers around the globe. The Red Cross, Red Crescent movement provides support to the people in need. Depending on the national context, the Red Cross, Red Crescent focus on areas like health and WASH, disaster risk reduction and preparedness, or anticipation. One of the biggest advantages of the national societies is the fact that they're working in the communities before, during, and after an emergency. They never leave. The community-based volunteers are always there to maintain activities and interventions. Although each national society is fairly independent, we are governed by 2 umbrella organizations, as you can see on the globe: the International Federation of the Red Cross, Red Crescent, and the International Committee of the Red Cross. Both are coordinating the international operations, guided by the 7 principles of the movement. Next, please. So in case of a declared emergency, emergency response units are triggered by the umbrella organization that can be either the Federation or the International Committee of the Red Cross, and they are part of their health response actually, based on the needs articulated by the affected national society. German Red Cross holds 2 emergency clinics and 1 emergency hospital, as you see here. Both the clinics and the hospitals are modular and interchangeable depending on the actual context and the need of the affected communities. Naturally, the continuous improvement and adaptation of these modules, for example, the reproductive mother and child health module, is necessary to follow humanitarian standards. Next, please. Both the sphere standards for humanitarian actions and the standards for emergency medical teams by WHO are the guiding standards for our deployments. Access to family planning is including access to wide range of long and short-acting contraceptive methods are considered as minimal standards. So the need to integrate these new standards and family planning into the emergency response units of the German Red Cross became imminent, and we clearly defined it as a gap, and this is when the window of opportunity opened for collaboration between German Red Cross and Bayer. With this project goal in mind, that family planning is becoming an essential part of our SRH interventions in humanitarian settings, we have started our collaboration back in 2019. So I just want to give you a brief overview of what we're developing so far. We're working on a family planning module, which components you can see here on the screen, and they all support each other. The special situation we have is that we know that perception of and access to family planning services are highly dependent on the national context. We needed to create something that could be easily adaptable to the needs of the local community, but at the same time being ready to be deployed within 48 to 72 hours. So that made it a little bit difficult in the beginning, but these are the results so far. Core components are the key documents, guidelines, job descriptions, training and training material for healthcare professionals and delegates, a functioning supply chain, as you already mentioned, education material, monitoring tools, and of course, a search personnel, like trained staff who is able to provide the services. Within these 5 core elements, we have focused on topics like protection, gender and inclusion, capacity development for staff and volunteers, before preparedness and during a deployment, unbiased counseling, the freedom of choice for women and couples, and of course access to long and short-acting contraceptive methods within the means of an emergency. As piloting and evaluating these components in an emergency was one of our indicators in our project, we have decided to look out for a partner because we cannot plan emergencies. Luckily, we can't. So, next, please. So, components of this module are being piloted in Colombia together with the Colombian Red Cross. We decided to look out for a partner to test our material. So we were looking for an environment where we would find a similar setting to an emergency. Meaning, in this case, a high influx of people on the move, or internally displaced people. This is the environment we were looking for. But at the same time, we were also looking for a partner national society who has a high interest and strong capacities in health and sexual reproductive health, who would have the strength actually to implement a pilot on short notice. And through a defined screening process, we chose the Colombian Red Cross as an implementing partner. The situation for those of you who don't know, the situation in Colombia is characterized by a large number of migrants coming from Venezuela, victims of the internal conflict in Colombia, and marginalized indigenous people who all have in common that they have very high needs in health and very restricted access to healthcare services. So since July 2022, the family planning pilot is implemented in 5 different project sites, mainly in border regions and in areas which are hard to reach. The target groups are reached by healthcare professionals and trained volunteers through mobile and fixed clinics. So I just want to give you a little bit a brief overview of the first results of the pilot. So our target was to reach 4,000 women within 6 months of the pilot with consultations, and out of these we aim to or we estimated 3,300 would finally select a contraceptive method of their choice. These numbers were based on research experience, but also on the number of women we're aiming to reach within an emergency deployment. What we see now, or maybe it's hard for you to see, but what we see now is that these numbers are almost identical. We have, in 3 months, we have reached almost 1,900 women. And one answer you see here in the picture. Women receive additional counseling about contraceptive methods before entering individual consultation sessions. This is done by staff and volunteers of the Colombian Red Cross. A detailed consultation and the high demand of family planning methods are the other reasons. Through informal communication and knowledge, women know that the only provider in their area is the Colombian Red Cross. Next, please. And surprisingly, out of almost 1,900 women, 87% received subdermal implants. Maybe you are surprised, as we were when we saw these numbers. Yeah, well, we see it's a disproportionate high number of subdermal implants being used in these 5 project sites. Based on research, we have expected a different distribution of the different methods. It became evident that these first results and numbers reflect the special needs of the population served. It cannot compare to the general population of Colombia. Women who travel long distance to reach a Red Cross facility, who might have crossed borders as well, cannot come back for in a few months for new blister or new injection, but still want to avoid pregnancy. Therefore, the implants are mainly used by migrants who are not coming back, or where access to family planning services is very difficult. Injections and oral contraceptions are mainly used by pendular migrants. As you see, the insertion can be easily done by a trained provider, as we see here, even in a mobile tent clinic. The benefits overcome potential risks and complications, and the women receive intensive counseling before the procedure to ensure they have chosen freely. And these results, of course, will also feed into our lessons learned. And we have learned our lessons on many levels. For now, I would just focus on the operational side, and since the project is not finalized yet, we have a few months to go, I focus on what we have learned so far. So although, and I'm sure you all know that the need to access family planning services is seen and acknowledged with the Red Cross, Red Crescent movement, the prioritization is almost low, is low. It's hardly never seen as an intervention with high priority. Therefore, our focus within the family planning project laid on advocacy. So we're trying to aim to reach larger groups of people, both stakeholders, decision makers, and of course the target communities via social and mass media campaigns using the developed advocacy material. What you also see here are the trainings we were conducting at the Colombian Red Cross and in German Red Cross in Berlin, we assumed that a lack of clinical skills and knowledge would lead to fewer utilization of long-acting contraceptive methods. And I already heard this in some other presentations as well today. We put a strong emphasis on these skills during our training for healthcare professionals. In our family planning module, we are providing the copper IUD and hormonal implants. And what we have done after conducting these trainings, the evaluation proved us right. It showed that the clinical healthcare professionals and also those in managing positions strongly benefited from the experience and the sessions on clinical skills, because mainly they got a better understanding of risk and benefits and the clinical procedures. And in the next step, as we already learned that, we would also would recommend to certify the trainings with associated medical boards, for example, nurses, midwives, and doctors. The high need of a flexible stock of contraceptive methods was another learning of the past months. And example, Colombia. Although the basic stock is necessary to ensure short notice deployment within 48 to 70 hours, we highly recommend, if possible, local procurement, meeting the national quality standards, and also adaptation of the selected methods based on cultural acceptance and local needs. Therefore, we would also recommend conducting rapid health assessments in order to meet the needs of the community. Another lesson that we have learned is how two partners can actually work together from two different organizations. Next, please. Welcome to the dance class. This became a common motto and saying. Although we've had the joint vision of creating something together, the family planning module, and we had strong experts on both sides, we have quickly learned that speaking the same language and using the same words would not mean the same understanding. There was miscommunication and frustration and question marks. We understood that there were different styles in communication in a corporate company and also in a humanitarian organization. A guideline, for example, could be a scientific document with lots of very needed evidence-based information, or a hands-on handbook that can be applied in the field during an emergency, where you don't have time to read hundreds of pages. What helped us overcome these challenges? First of all, it was the curiosity and the openness to learn from each other, both sides, and the shared vision to create the family planning module together. We achieved milestones together, like creating storyboard for an advocacy video, planning and conducting trainings for healthcare professionals. These milestones helped us to overcome the challenges and to understand each other better. We managed to, in regular meetings and workshops, to truly exchange knowledge, and know-how was transferred to both sides of the table. Like in a dance class, we slowly understood each other better. And last but not least, both partners also understood the benefits of a cooperation while creating something together on a corporate level. The development of a new product, which is close to both partners, German Red Cross and Bayer, and the impacts of the ongoing cooperation for different levels in the companies. At German Red Cross, we do see this as a best practice model and something we want to scale up. So with the experience we have made in the last months and throughout the development and the lessons we have learned in piloting and testing in Colombia, we came to the conclusion that we see the module scaled up. Next, please. Although the original project outcome included a scale-up through the International Federation of the Red Cross Red Crescent, but mainly within those 6 national societies, which also hold clinical or public health emergency response units. And although the variety of SRH activities within the movement is enormous, it's not enough to meet the needs of the community. In many cases, the focus lies around maternal health, HIV, or menstrual hygiene management. Family planning is more likely to be a topic untouched. We see the future in a harmonized approach to integrate family planning into the public health activities and strategies for a larger number of Red Cross or Red Crescent societies, which at the end will increase the impact and allow peer-to-peer learnings within the movement. Part of the scale-up would also be to identify strong partners and national societies who also work in the field of SRH and who have a strong interest to improve and a high motivation to implement. One of the core elements are always capacity development and safe and respectful access to family planning services. We do that either through Red Cross, Red Crescent facilities, referral systems, or cash and voucher. Education and information in the communities. All of this, we do see the future of a harmonized community approach within the movement. And with this being said, I'm coming almost to an end. Almost. You see a lot of people here, and I'm here all by myself. I'm not all by myself, I have some partners here, but there is a big group of people behind this project, and all of them helped us, because our project would not be alive and striving without all of these who put their heart, their energy, knowledge, skills into it. And of course, our gratitude goes to the partners at the Colombian Red Cross, who piloted everything that was developed at the desk in Germany. That was a very touching moment, seeing something happening in Berlin 1 month and the second month in Colombia. And they're giving us such valuable feedback and ensure also access to family planning services. So thank you. We have a last slide. If you have questions, we're happy to answer these later on, or you can approach one of us later. Thank you.
Thank you, Jana. I think from your presentation, the importance of tailoring and adaptation was super interesting, both in terms of how the module can be super quickly adapted as needed into different contexts, but then also thinking about the needs of contraceptive users in some of these contexts and how that might differ. In this case, in Colombia, the role LARCs played in kind of reaching their contraceptive needs. So now we are on to our final presenter. Our final presentation will be from Tariq Farman. Tariq is an Afghan humanitarian working for the Afghan Family Guidance Association. He holds an MBA and is currently working as a project coordinator at AFGA. He has implemented Australian-funded projects such as Sprint 3 and humanitarian response projects with IPPF within Afghanistan. Tariq, thank you.
Thank you very much. 124, 124. The 3 is missing. I believe the mic has some problem. Just kidding. So in order to, I had an instructor and he always encouraged me to start your presentation with a question. I wanted to ask you all if anyone can answer, what are the 2 things that can't be eaten for breakfast? Can anyone answer? There are 2 things that you can't eat it in breakfast. What are those?
Lunch and dinner.
Perfect. Give him a hand. So Eric, I wanted to ask one question. Is I have some experience in terms of being an instructor. So I want my session, if possible, if anyone has any questions inside the session, they can interrupt. And I'm really conscious of the time, the 15 minutes. Yeah. So I can guarantee that. Yeah. Thank you very much. As you can see, the topic is covering the last mile through community outreach midwives to deliver essential SRH services in fragile setting. This is a case study from Afghanistan. And I am Tariq Farman, and I'm representing Afghan Family Guidance Association, which is a member association of International Planned Parenthood Federation, or IPPF. Next, please. So the agenda of my presentation is I'm going to explain a Stream 3 project, and also apart from that, the design of a Stream 3 project, and also what sorts of sexual reproductive health and rights services were provided by our service providers, and also the achievements and challenges. Next slide, please. Yeah. So the Stream 3 project, it's a humanitarian fund that is supported by IPPF, and as it is indicated, it's going to be implemented while a humanitarian crisis happens. And when we were implementing a Stream 3 project, and we have planned to implement this project, the ground reality was in a way that Afghanistan unfortunately experienced political deterioration, and that led to a humanitarian crisis, and also in a normal situation in my country, the humanitarian situation was not good, so we can imagine what will happen in fragile settings. And then there was the COVID-19, so it affected countries, all the countries, and some countries in many ways. For example, in our country, it was the first and the third round that was most affected, our people were affected. And then there was limited vaccine provision, and also limited and poor diagnostic capacity. So in this project, fortunately, we were happy and we were lucky that we won't have to recruit new staff, because we already had a trained staff from a Sprint 3 project, from a Sprint 3 emergency project. And also this Sprint project is a coveted project from DFAT, Department of Foreign Affairs and Trade. It is being led by Australian government's response to international humanitarian crisis. And also at that time there was lack of health facilities in remote areas, and also lack of enough health workers. Next slide, please. Yeah, so the design of this project was to provide MESP services during the pandemic and after political deterioration. I wanted to ask how many of you have heard the name of MESP, or Minimum Initial Service Package. If you do, please raise your hand. Impressive, that's a good number. So MESP project is MESP package is developed by UNFPA, and like it is a set of prioritized activities that is designed to manage the 6 objectives of MESP. So apart from providing MESP services, there was like 65 community outreach midwives we had, which I'm using the short-term comms, and they were providing services to 5 provinces. And their target for 6 months was 78,000, meaning that for each month they had to provide services for 200 clients. And also distributing clean delivery kits for visibly pregnant women in remote areas. Next slide, please. These were the type of MESP services that our community outreach midwife were providing in clients' doorsteps. If anyone has cannot understand or haven't heard the term community outreach midwife, surely you can ask later. They were providing general family planning counseling, and also they were providing short-term family planning methods, and they were referring for long-term family planning methods to AFGA static clinics, and also they were referring complicated cases to there. They were also providing HIV and STI risk reduction counselings, GBV counseling, and referral information on danger signs of pregnancy and newborn, and also distribution of clean delivery kits and abortion, post-abortion counseling. So as you can see in this picture, the midwife is like providing HIV and STI risk reduction counseling, and also like she's providing short-term contraceptives such as like CUC, PUP, injectable for HIV and STI risk reduction. They are providing condoms, male condoms, and they are referring for long-term family planning method. Next, please. And one of the great thing is like the community outreach midwives, they are providing MESP services amidst difficult weather conditions, and they are the real champions. Next slide, please. Also, the community outreach midwives, they were like checking the client's blood pressure, especially for those who were pregnant, and they were like also providing counseling on eclampsia for pregnant women. Next slide, please. Clean delivery kits is very important during humanitarian responses. So fortunately, we plan to distribute 1,560 clean delivery kits for women in 3rd trimester, or visibly pregnant women, or women who are pregnant from 6 months to 9 months. This is the number of clients that reach. If you remember, our target was 78,000. So in the first month, in the month of November 2021, we reached like 5,550, and in January 28,392, and then it goes on, and on July 2,031. If you compare our clients versus target reach, so fortunately we have overachieved. Like in the first month, the number was low. It's mainly because of the mobilization on all these stuff. So that's why at the end we are happy that the numbers were dramatically increased. Yeah. Of course, there were some challenges, especially limited cash withdrawal. When the political deterioration happened, there was like some challenges through banking system, and also there was the sanction and delays in salary due to disruption of banking system. So AFGA fortunately mitigated these issues through putting in place a proper cash flow management to pay the for office related expenses, operational expenses, and also procurement of staff. So this was mainly decided by our senior management team, and they were prioritizing any activities that they think it's the best to be implemented. And also AFGA try to use bankers in order to achieve its to achieve the budget, and also they developed or created a policy for grant transfers through local bankers. Thank you very much. This was my presentation. Thank you.
Thank you, Tariq. I think, the role of those community outreach midwives that they play in their communities, from family planning to maternal health care, I think is so important. And the fact that despite challenges, the project was able to exceed its targets is very impressive. So thank you for that presentation. With that, we have a little bit of time for Q&A. If anyone has any questions, raise your hand. We can bring you a microphone. And if your question is for a specific presenter, just specify that. Otherwise, we'll open it up. All right. Oh, okay, thank you.
Hello, my name is Nin. I'm the SIH advisor for humanitarian program for IPPF. Yeah, I have to acknowledge the very excellent presentations for all of you. Thank you so much for sharing. My question is go to Christophe. Yeah, thank you very much for sharing that comprehensive, what you call is the concept framework. For that, in there, they have a few core elements. Can you share a little bit? And you also have trial in a few countries like Sudan, Malawi, South Sudan, and things like that. Can you share a little bit how you introduce, what is the process, then introduce that core concept to those countries, and who is leading in the process, for that nexus? Thank you.
Sure. Yeah, and so this, I think the short answer is not really. This is more of a research undertaking to help us kind of better understand how those. The framework is currently for us to get a better understanding of how that actually looks in the countries where we're doing those case studies. So I don't think we know that. We have we have colleagues heading to South Sudan in about 2 weeks to do the first of these, because this is very, very much conceptual. And so I think what we're hoping for, hopefully maybe by the middle of next year, have a better understanding in at least those 4 countries of what that actually looks like in terms of collaboration or no collaboration. So I think right now it's, again, still pretty conceptual.
We have a question in the back first.
Thank you for those very insightful presentations. My name is Josue Orellana. I'm Director for Health at ADRA International, and we do a lot of humanitarian work as well. I have a couple of questions. One is in general about cash work. Is there any room for cash work, cash vouchers, cash transfers when we do family planning and reproductive health services in humanitarian settings? And my second question is specifically about the experience in Colombia. I would like to learn what was the link, if there was any link, with the health facilities run by the Ministry of Health in Colombia, especially thinking about these long-acting methods like implants that will need probably some follow-up, some referral system for side effects and other things. Thank you very much.
Jana, I'll pass it to you first to answer the question on the...
Actually, I might have to pass that question on to my colleague Javier, who's sitting there from the Colombia, working in Colombia. So I might do that because he's the expert on that topic.
Yeah, the answer is yes. We work with the Ministry of Health in coordination with through the network. So the Colombian Red Cross has its own network, but everything what is done is coordinated with them. So the idea is that the people can have access to the public network when possible.
I think the second part of the question was in regard of the long-acting contraceptive methods, right? So from my understanding, and please jump in if I don't get it right. So we have trained staff at the Colombian Red Cross trained providers who are able to do the insertion, and it's the most demanded contraceptive method in our service point. So I cannot talk about the other regions. This is what just in our 5 project areas, it's the most demanded. And of course, it's done under standardized circumcisions. It's procedure is clear, and also the follow-up is not, it's recommended but not necessary if it's done by a trained provider. So I think this is why the migrants, or mainly migrants coming to the Colombian Red Cross, because then they might go back to their own country, back to Venezuela. But please correct me if I'm wrong. No, he's nodding. So.
And then I believe the other question was about the opportunities for cash vouchers in FP programs and humanitarian settings. So I'm wondering if Tariq, if you have any insight into that, or if any of our other panelists do too, feel free to answer.
Unfortunately, I have to pass that one.
No problem. Yeah. Anyone else?
So for the Red Crescent movement, there are national societies who are working on cash and voucher systems. It's not, family planning is not a part of it yet, but we're looking into more getting health into cash and voucher systems even more. So family planning then will be a part of it, but I can't give you any more details now. This is a project for the next coming years.
I'll also kind of dodge the question as well. As a development organization or as a development project, that piece is not something that we necessarily focus on. But I do think it raises the issue of multi-sectoral collaboration, which both in the humanitarian sector in particular, but I think really in fragile settings where our project is operating, I think are really important, whether it's with livelihoods, agriculture or education, even thinking about how you can integrate within those across sectors, because we're often seeing other sectors having far greater reach into communities than the human health sector. I've had to learn to talk sometimes about human health versus animal health in particular. So again, not answering your cash question, but kind of thinking about things from a multi-sectoral standpoint, I think is really, really important.
Thanks, everyone. We have another question over here. Sorry. She's bringing it.
Yes, thank you. Jamila Sharai from Yemen. Yemeni Association for Reproductive Health. We are a member with IPPF. I have a question to my colleague Tarek. You mentioned that in this project you have midwives, and are they the same midwives are working in the health centers in these areas? This is the first question, and how many they are. You mentioned that they deliver clean kits to the pregnant women in these areas. So are they attend with women during delivery, or just distributed the clean delivery kits to them? The third question is about MISP. You mentioned that MISP is one component of this project, and we know that MISP means that we have RH kits to use it during our work on MISP. Did you have this kits with the midwives or in the health centers? Because what I understand from your presentation, that the midwives make a referral to the health centers, and women, if they need long contraceptives like Implanor or IUD, they have to go to the health clinics. Thank you.
Thank you very much. Thank you. Yeah. The term, as it indicates, the community outreach midwives were only providing services in remote areas, especially in places where those areas were far from health centers. We are experiencing some of the areas that may have few health centers there, but unfortunately due to lack of human resource, that's why we don't have enough people to be in that health center. That's why we thought that these community outreach midwives are really useful to provide services in those types of areas. The second question, clean delivery kits were distributed to visibly pregnant women, especially for those who were far away from health centers. And as you know, that this clean delivery kit is really effective in terms of preventing infections during the delivery. And Of course, like we had like reports from community outreach midwives who attended this delivery, and sometimes most of the times they were attending, and they were part of the delivery as well. That happened. And as you said that the RH kits, I believe like clean delivery kits, as you know, it's like the second kit of RH that is in the RH manual that was developed by UNFPA. So we had like clean delivery kits and distributed among the visibly pregnant women. Yeah, thank you very much.
Great. I think we have time for one or two more questions. We'll go. Thank you.
Thank you very much. I just want to acknowledge the very informative presentations that you have made here this evening. Apart from Tariq sharing with us the systemic challenges that he encountered, I just want to put across to all the presenters today, beside those systemic challenges, were there outside systemic challenges that you face, and how did you address those challenges to improve your response to population in crisis? I work with National Population Commission of Nigeria, and my name is Margaret Edison. You know, we have a lot of issues of crisis of humanitarian and responses. And my second question is, use the same strategy for the different settings of humanitarian needs?
Who would like to start with the question on the systemic challenges and how it was addressed? Anyone?
I might just say one thing. From our perspective, it wasn't necessarily an effort in the humanitarian setting as it was the challenge to bridge that divide between humanitarian workers and the development workers, which, as I was saying in the presentation, isn't something that is a reflex in either community. So bringing those two groups together and getting them to speak the same language was maybe one of the challenges that we had, but I think that we effectively were able to overcome that. It's still, as I said in the presentation, there's a lot of work still to be done for those two groups to be working together, and all those different sectors, the donors, the NGOs, humanitarian development agencies, and governments to be working together. So there's still certainly a lot of challenges. So I'm not sure that answers your question exactly as you posed it, but from our perspective, that was just one that sticks out in my mind. Thank you.
Anything else to add? I think the other question was also on whether the same strategy or approach is applicable across all humanitarian settings, or kind of the need for adaptation and specific approaches based off of analysis of the particular setting. Tarek?
I'm sorry, although you said apart from Tarek, but I would love to answer this. Certainly adaptations is good, particularly when you have information about the fragile settings. For example, within Stream 3 project, since I said it's a humanitarian response funded project by IPPF, so we had like different projects by the name of Stream 3. For example, the first one, we wanted to ensure the continuation of sexual reproductive health services. So that's why we planned for 65 comms. Later on, an earthquake happened in Afghanistan, which was 6 magnitude, and it really affected that particular province. So we initiated this Stream 3 project by creating 2 fixed clinics and 2 mobile clinics. And on the other hand, there was a flood that occurred. We planned for 2 mobile clinics only. So adaptation is good, and particularly based on the decision that what are those community really in need for. Yeah, thank you.
Let's take one more question.
Thank you very much. They were very interesting presentations. You mentioned challenges with the nexus between development and humanitarian. Maybe you can tell us a little bit about that, because these are challenges that we all face. The second one is there's an emphasis on international guidelines. To what extent do you also use national protocols? What role do they play? And the last one is the focus on localization, especially for those in the nexus. To what extent do you engage with the people that you work with on the ground? This is for the three of you, because I know that Tariq is speaking for Afghanistan. Thank you very much.
Right. So we have the role of national guidelines in addition to the international guidelines. And then also the first question was on a bit more about the challenges between humanitarian and development collaboration.
Yeah, I could start. I mean, the Red Crescent movement is a little bit special because we always work within the national scope of the country that is affected, or the national society that is affected. So there's, I mean, of course, like for emergency response units, there are standardized guidelines. OPD is always in OPD, yeah, no outpatient departments, never changing. But of course, material and strategies, national policies are always on top of it. So that in the movement, because there's a national society in the place already, and there's staff already there and volunteers already. So that makes it a little bit special for the movement, because we don't, as a German Red Cross, we don't act in another country. We're acting in behalf of someone. So I hope that clears that up a little. Back to you.
Chris or Brian, anything to add about the humanitarian development collaboration?
I mean, I could go on with challenges without solutions for a really long time. But again, I'm gonna put in another plug to come check back with us in, I don't know, 6 or 8 months, because I do think some of these case studies that we're doing, I hope we're really going to find how some of this actually looks on the ground, because I do think we talk about the humanitarian development nexus as, I talked about a conceptual framework for it, and I think we talk about it at a conceptual level and kind of a theoretical level a lot. And there isn't as much of what does that actually mean if you're a community, if you're a district health officer, working out somewhere, and you have, development actors that you're partnering with, but you also have humanitarian funding coming. What does that look like for you? I don't think there's a lot of documentation around what that looks like. So I'm hoping from that we'll kind of get a more realistic picture of what it looks like. So again, I don't think I have a great answer for you on that yet, but hopefully soon we'll have some answers.
Great, thank you. And on that, we are at time, so I just want to do another big thank you to our 4 presenters. And thank you to all of you for joining.